on the eye acroform. But let me now introduce our speaker, Professor Dr. Jaime Vera. Jaime is a professor in HIV medicine and the head of Department of Global Health and Infection at Brighton and Sussex Medical School. He's also a consultant physician for the Lawson HIV unit at the Royal Sussex County Hospital in Brighton, UK, where he is the lead physician for the combined HIV and geriatrics and memory clinics. Jaime's research focuses on the study of comorbidities affecting people with HIV and the development and evaluation of innovative models of care for people with HIV with comorbidities and memory impairment, including interventional studies aimed at improving quality of life and mental well-being of older people with HIV in both low and high income settings. I'll hand over to you now, Jaime.
Thank you very much. I just want to make sure that you can all hear me. So I'm going to share the presentation. And of course, I couldn't share it. So I think I need you to documents. Apologies for that. It's always easier. And then for some reason, I can't find the presentation. Well, failing that, maybe you can share it for me because for some reason, sorry, I've done it now. Didn't start very well. Anyway, can you see the presentation now?
Yes. Yes.
Well, thank you very much for inviting me to kind of really share our experience of incorporating clinical geriatrics into HIV care. And it's really just sharing the experience of a service that we've been running for quite a number of years now, called the Silver Clinic, which was the first clinic, I think, in the whole world that was combining geriatrics and HIV medicine in the setting of HIV services. These are my disclosures. And I just wanted to start with this because I think just to give you a feeling of what is the situation in the UK. We don't really have many patients in the UK compared to other settings, particularly settings where perhaps you are. We have only around over 108,000 patients now living with HIV. But you can see is that the number of people that are actually getting care in England is getting older, and it's getting older year per year. That sort of bracket of people over 50 years old and even people over 65 and over is also getting older. Brighton is a particular place because compared to the rest of the UK, about 68% of people living with HIV in the city of Brighton is over 50 years old. And we might argue about whether 50 years old is older or not, but I think traditionally in aging research, that has been the cutoff. What it means is that we have the oldest cohort of people living with HIV in the UK and one of the oldest cohorts of people living with HIV in Europe. It's a special place because we really train is by the seafront, so lots of people want to come and retire in Brighton because it's one of the kind of warmest places in the UK. And for those that have been in the UK, it's very rainy, so people pay and move to wherever there is a little bit of sun during the year. This is our kind of new hospital, the sort of Royal Sussex County Hospital, and actually our HIV unit, as it happens, is around in this building. So we have a really nice view of the sea. We have around 3,000 patients living with HIV, probably across the whole of the sort of Sussex area. Most of the demographics of our patients are men that have sex with men of what ethnicity that are older. We do have a cohort of older, also women living with HIV, but really this is a minority. The vast majority of our patients are from that demographic. So, obviously, before the introduction of combination antiretroviral therapy, HIV medicine really was very different. And I think we used to see a lot of people, particularly younger people, with opportunistic infections, but that really not the type of medicine that we're doing right now in Brighton. In 2025, this is more what we are seeing and the type of patients that we see on a regular basis. This is actually one of my patients. And you can see that there are different sort of complexities here. Not only people are older, But if you look at the HIV markers, they're all stable. So actually the HIV is the least of the problems that these patients have in theory. But they have multiple comorbidities. They also have issues with polypharmacy, which are quite common, not only to control their HIV, but also to control all the other comorbidities that these patients have had. And also there are also other sort of social determinants of health that are complex. People tend to be more socially isolated, for example. People tend to be more financially insecure, and there is a huge burden of mental health illness as well among people with HIV, particularly here in the UK. In the case of this individual, 64 years old, again, HIV well stable, kind of multiple comorbidities. Clearly, this got some specific issues about social isolation and also clinical depression, which is important. But if you highlight these, some of the issues that we are seeing in terms of geriatric syndromes, issues with falls, poor mobility, and sometimes things that we just don't ask about. Particularly ID physicians tend not to ask about these things, apart from geriatricians, really, in terms of fecal incontinence, for example. So obviously, clearly, this gentleman looks frail. Sometimes you don't need a tool to be able to determine that someone is frail. Sometimes, as many geriatricians do, just by looking at patients, they know whether these patients are frail or not. What is the standard of care for people with HIV in the UK? And I'm going to put here post-COVID because obviously during COVID things change a little bit. In the UK, we tend to kind of see patients face-to-face at least once a year. Normally, nurses tend to do an HIV annual check, which is conducted once a year, where they do different type of screenings for many things that have been recommended by the British HIV Association and the European AIDS Clinical Society, things like hypertension, diabetes, also screening for things like mental health and so on. So that happens once a year, and patients usually tend to have blood tests 2 weeks before they come and see the doctor. When they come to the HIV doctor or the ID doctor, that happens again about twice a year. It's about 20 minutes consultation. And really is up to not only nurses and doctors from the HIV unit to be able to actually share that information with other services, general practitioners, family practitioners, and also other hospital specialists and social care services if needed. We do have the ability of doing video calls. The reality is that people don't like that. We also have the ability of using the telephone for telephone consultations. People do like that, and sometimes we use it. And is becoming particularly important, particularly for those older patients that want to stay at home and have difficulty mobilizing. We also have a community HIV services that actually can go to people's houses, being able to take blood tests and do assessments, including frailty assessments. And we have obviously an application that helps patients to kind of manage a little bit of their HIV care, where they get blood results and appointments and reminders and so on. So this is the sort of a standard of care that we see. But you start seeing what's happening with a patient like the one that I'm presenting here, and it's this polydoctory, is how you coordinate all these things that this patient might need. And normally that coordination actually lands in the HIV service, and that can be quite challenging because we only have 20 minutes and we have many patients. And in the case of our setting, we have a lot of patients with these complexities. So it's up to sometimes the patients themselves to be able to navigate these services. Do they need an appointment with the neurologist, the psychiatrist, the pharmacist, the GP, etc.? And what it means is that these patients need to remember all these appointments, need to coordinate all these appointments. And it can be quite difficult for someone. Let's say they have cognitive impairment, they might remember the appointments, they might have double booking, they're socially isolated, sometimes they only live on their own. They have difficulties, they cannot even hear sometimes. So you start seeing the difficulties of how, even if you cannot send a patient for an appointment, it might be quite difficult for them to attend that appointment. And then they come back 6 months later saying, well, I haven't done it. And you're like, oh, I have to do it again. So I think it's important to understand the context. So what are the clinical pathways for people with HIV with these type of geriatric symptoms like frailty and so on? So in the UK, you can just send patients to the general practitioner and say, look, this patient is frail. Can you please deal with the falls and so on? You might be able to send them to hospital specialist services to each specific sort of condition, if you like. Sometimes geriatricians might take these patients, but because of age and they don't think that they can They sometimes in some settings, not in Brighton, but in other settings, they just don't accept patients unless they are of certain age. What we see though is that a lot of these services, and a lot of patients that tend to attend these services have issues, and sometimes they just don't go. So only about 80% of people in the UK actually want the GP to know about their status because of fear of stigma. So you already start seeing some barriers there. We talk about the multiple appointments, and also we talk about services that perhaps are not familiar with the complexity of managing people with HIV. And we tend to kind of have this a lot. When we send patients to the gastroenterologist and they come back to us and they say, look, this is the HIV, is nothing to do with gastroenterology. And we're like, this is not the HIV. The HIV is well controlled and so on. And also they get scared about the antiretroviral therapy. Also, patients are very different from the standard patients that they tend to see. Some of our patients tend to drink more, take more recreational drugs and so on, and have a lot of mental health issues. So you can see all these sort of different barriers. Now, if you're lucky, there might be another route for this, which is not an easy route, but there's been, and I know you have discussed this, and some of you already have started these processes of kind of integrating geriatrics into HIV and developing these sort of unique nuanced models of care for these patients. So going back into what is the Silver Clinic and the service that we set up, really is not rocket science. This was an idea of combining geriatric knowledge with HIV knowledge in the context of an HIV service. And really what the geriatricians do here is the comprehensive geriatric assessment, which is again, no rocket science, is what geriatricians do as part of their order management of patients. It's a very patient-centered care type of care, is very holistic, is focusing on the 5 M's: mobility, mind, medications, multi-complexity, but also more importantly is what actually matter most for patients. And that's the principles of patient-centered care. This is the patient's agenda rather than the physician's agenda, if that makes sense. We tend to do this clinic once a month. We have 2 geriatricians now doing it because of increased capacity. We normally offer time, and time is precious in medicine. We offer about 40 minutes per patient. The clinic is actually located physically in the HIV services and is facilitated by that. We have an HIV nurse that does the coordination of the appointments and making sure that all the assessments are done before the patients come. And we have support from HIV pharmacists and therapists as well, because there is a lot of issues about deep prescribing, for example. Well, the outcome of this clinic is to produce an individualized care plan that then we can share with the HIV clinic or the HIV physician that is looking after that patient, with hospital specialist services if needed, and also with the general practitioner if the patient has consented for us to do that. We don't want to replace the HIV physicians. I don't want to kind of take over all the patients over 50 years old. Otherwise, I wouldn't even leave the house. Because it will be just too busy. But what we want to do is making sure that we can actually help with that complexity to be able to manage these patients in a little bit more holistic way. This is a sort of very simple referral form. It's electronic now, but just to kind of give you an idea about the type of things that we are seeing in terms of mobility, difficulties with activity or daily living, multimorbidity, frailty specifically. And I'm going to talk because we're doing some screening of frailty a little bit later. False issues about mental health, illness, polypharmacy, or other things. What we do is normally patients, before they come to the clinic, they tend to have this sort of a standard blood test that normally geriatricians do for all patients that come to the geriatric services. PSA, patients are getting older. We have a lot of men. And, in terms of screening for prostate cancer and so on. We do also frailty assessments, tend to do the FREED assessment and the time up and go test, which we found that is very sort of easy to do and implementable. We also do a lot of sexual health screening. We do DEXA scans in all people with HIV over 50 years old as a standard in our clinic. And we also use patient-reported outcome tools to be able to help us during the consultation and also to assess things such as mental health, for example, using the PHQ-9 that you might be familiar with, and also assessing cognition using the MOCA. Although again, cognition kind of goes into a different pathway because we have a memory clinic for people with HIV. I want to talk a little bit about this tool called the Positive Outcomes. It's an HIV-specific patient-reported outcome tool, and we use it very much in our clinic. And it's really developed and it was co-designed with people with HIV within the UK, and it has different domains. But to me, the most valuable thing during the clinic is this bit where patients, the question that they have is, please answer the following questions. And really it's about assessing what's happening during the last 4 weeks. And this first question, what have been your main problems and worries over the past 4 weeks that you would like to be addressed? This is very helpful for us because it helps us with that aim of, what it matters most to patients. And you will be surprised that sometimes patients, you read the story, you do an MDT before you actually get the patient into the room, you read the notes, the referral, and so on, and you have some ideas about what exactly is the issues. And actually, what patients put here might be very different. So you can tell that it's already kind of guiding your consultation. So we found it very, very helpful. And we just look at this data recently. In about 54 patients that completed this form. And you can tell here that the reasons for referral, for example, from the physicians were a bit different. So issues about polypharmacy, issues about pain, issues about impaired mobility. And this is a sort of a scoring, so kind of medium score. But to me, the most interesting bit is the bit about the sort of free text reported problems. And lots of these patients have physical problems, also cognitive problems and psychological problems. Let's say these are the sort of most common ones that people tend to kind of have. A lot of these prompts assesses all other things like welfare, social relationships, and also things like information and whether enough information these patients have. But it just gives you an idea about what are the most common complaints of people, and also how the clinic might be able to address those. Um, as I was mentioning before, the main aim of what we do is develop this individualized care plan, and that might mean that we might formulate health interventions, could be more investigations, referral to other specialties, might be referral to occupational therapy, social services, psychology, or even community services such as exercise interventions, peer support groups, and so on. So really the objective here is not to cure every single illness that these patients have and get them back to be 25. I think really is about improving quality of life with all age. And I think patient-reported outcomes might help us to measure this a little bit better. It's something that we're kind of starting to work on now, how we use these tools to be able to measure that improvement in quality of life and well-being. Now, this is how the clinic actually functioned for many, many years. Most of the referrals, we were getting it from the HIV physicians and ID physicians themselves, based on the multi-complexity. Basically, they were just struggling with patients with 20 minutes to deal with everything else because all the HIV was well controlled. So we decided then to kind of use or take the opportunity of the HIV annual health check to be able to screen for frailty. And that's something that we incorporated based on really some some work that Fatima Brañas from Spain has been doing with EACS to kind of develop this algorithm for frailty screening. And the suggestion is that we should be screening all people with HIV over 50 years or for frailty using really anything that you can actually implement. And then those that have frailty have this sort of access to geriatricians to have a comprehensive geriatric assessment and developing this a care plan, which is similar to the individualized care plan. So obviously we've been doing this for a while. The question is, how can we incorporate then a screening for frailty? And lots of questions about algorithms. You look at this algorithm, there isn't really any information about, how should we talk to patients about this? Who should be doing this? Is it going to be the doctor that should be doing it, the nurse, another allied healthcare professional, the GP? How often should we do it? What patients come every 6 months? Should we do it every 6 months? When we should be doing this? And how we should be doing it as well, even where we should be doing it, in which part of the clinics, because sometimes it's recommended to do free assessments, but that can take time. And also what happens next, because you might be a screening for frailty and identify that someone is frail and have multiple geriatric syndromes, but you need to have pathways to be able to manage these patients. There is nothing good in a screening when you have nothing to offer to patients. So lots of different questions. So I just wanted to ask you, really, and this is when hopefully you guys can help me about which strategy might help reduce stigma associated with the term frailty in HIV care. Because that first thing is important. If you're going to be starting a screening looking for frailty and geriatric syndromes, you really need to kind of find out what people know about this, your population know about this, and the term of frailty, which also is stigmatizing. So you can do this. It will be interesting to know what you think about this. And again, at the end, we can probably discuss a little bit on this. Great. So in order to do this, and even before we thought about starting frailty screening, we actually did a piece of work that was done by one of my PhD students, Natalie St. Clair Sullivan, who is actually defending her PhD today as we speak. So she did a lot of qualitative work looking at the perceptions of patients and healthcare professionals on frailty and the implementation of frailty screening in HIV care services. And you can see here that, for people with HIV, they have different sort of perceptions of what frailty is and, what screening for frailty could involve and how that is perceived. And if we look just at the term frailty, and I think, it's very medical term, it's quite negative, but I think patients acknowledge that perhaps there are not many alternatives there. Sometimes frailty is not a type of concept that in many cultures, for example, or languages even exists. Tends to be very much confused with dementia, for example. So people say frailty is because someone is kind of going a little bit lolly from the brain rather than, the physical frailty as we know it. Some people do see some positives because if you identify it early, perhaps you can act upon it. You can be a bit more proactive and trying to slow the process, make some life adjustments, trying to improve quality of life, trying to kind of redefine what the strength really is. But also they might see some sort of negative outcomes in terms of, well, do I really want to know this? Uh, Perhaps it's something that people start kind of losing autonomy, and it's a recognition that this might be the case, and some patients don't want kind of extra help, although they might be needing it, and so on. And you start thinking even about the fact that some people are going to require care homes, for example, that sort of loss of sense of sexuality in care homes is going to be very relevant. We also talked about when to discuss frailty, and I think for some people they just want it very early. Some people wanted it later of in life, but most of them just kind of said to us, "Look, we want the healthcare professionals to actually decide this," and they prefer to kind of have this done at the routine HIV assessments rather than the GP. But for some patients, this is not an issue. And in terms of tools, they don't really mind the tool. They just want, if we're going to be doing it, then just do it, basically. So the tools are interesting because there are a lot of tools out there that are used for the general population. And the question is all this validity with HIV. There isn't really a way. Validating tools can take a long time, years and years to validate a tool within a population. And I believe that we don't need to wait because it's not very different. Our patients tend to have frailty a lot earlier than in the general population, but the physical manifestation of frailty is very similar. So you can tell here that some of these tools, for example, take about 5 minutes to do, require space and so on, and some of the clinics don't. So we consulted with our nurses, and they decided that for them, the best tool was going to be the Frail scale, which is self-administered. You can see here on the right, and it takes about 3 minutes to complete. It's something that patients actually do. It's been validated in the general population and is mainly implementable in our service. So this is
You
our
have
pathway.
5 minutes.
Perfect. This is our
Okay.
pathway. So we have our HIV annual health check, and then if someone is robust, we do general recommendations. If someone is pre-frail, we sometimes discuss it with the team and decide whether they need or not come to the clinic. And if someone is frail, they are offered an appointment to the Silver Clinic. You notice here that we are screening only over 60s. We simply have too many people over 50s, and the nurses refuse to actually do a screening to all over 50s because it would have been almost the whole of the clinic. So these are the results of our exercise. So about 77% of the cohort of people over 60 years old were screened for frailty. And you can tell here that roughly we found about 12% of people reported as frail, which is comparable with the data out there. But interesting, about 10 people just declined. They were frail and they said, no, thank you. I don't want to kind of go to the clinic. I haven't got time. I just want to stay at home. I have too many appointments and so on. So just to kind of show you that even if you offer these things, it might be people that don't want to kind of take it. This is just to give you an idea about the population that we have in the clinic. You can see here that tend to be younger that you will normally expect in a geriatrics clinic. And again, just an idea about the levels of other things like comorbidities, medications. This is not very different to what is being published there. And in terms of pediatric syndromes that we see in the clinic, you see here things like frailty, mental health issues, mobility issues, and so on, cognitive decline, and social isolation. So we started doing this, which is mixed method study, just looking at what is the impact of the Silver Clinic on different outcomes. And I think what we found is that people really like the service. They really do like the service. They have time. People listen to them, and some of their issues get addressed. What we found in this feasibility study as well is that there was some improvement in the time and go test following attendance to the clinic and potential improvements in quality of life. So this is the first time that we have shown that actually doing a comprehensive geriatric assessment in people with HIV might have some benefits for patients and is highly acceptable. So for you, and I'm going to finish here now, it's about building an evidence base if you want to do this. Do a lot of service planning. What do you have in your existing services that you can adapt? Who can you talk to? Do a lot of education and training of healthcare professionals and involve patients always. Because again, one thing don't fit all. You need to find a way that actually doing this in your own service. I'm going to leave this because it's going to be the end. And just to kind of give you the summary here. And maybe we just finish with a question and start the discussion. And thank you very much for listening. So the question really is about what is the biggest challenge that you have in your own setting in scaling up integrated HIV and geriatric care services? What is that is stopping you from actually doing this? And just some acknowledgements of the team. So the two geriatricians, Julia Wright and Tom Levitt, and Adam, who is our nurse. We set up a network within the UK called the Chain UKI, is UK and Ireland as well, just to kind of discuss these issues about aging, just to ensure that we standardize what we do in many services across the UK. Thank you very much.
Thank you very much, Jaime. That was an excellent presentation. Very inspiring to see this service in operation. And I think you're right. This is, as far as I know, the only service that incorporates geriatrics and HIV in one setting. So well done. I think we're going to do questions at the end when we have the Q&A. So we might go on to our next presenter, Dr. Noor Hazana. Welcome. Dr. Noor Hazana Binti Haroon is a dedicated family medicine specialist based at Klinik Kesehatan Bestari Jaya, with a strong focus on geriatric care, community health, and primary care transformation. Since completing her master's in family medicine and subspecialty geriatrics and primary care, she has led numerous initiatives aimed at improving the quality of care for the elderly population. Her clinical interests include frailty screening and interventions, chronic disease management in older adults, and integrated elder care services. Dr. Hazana is also a key contributor to national guidelines, including breast cancer management in older women, and has led quality improvement projects in diabetes monitoring, wound care, and patient-centered approaches for aging populations. As a principal investigator in the COVID-19 vaccine trial among children and an active member of the Malaysian Family Medicine Specialists Association and WONCA, which is the World Organization of Family Doctors, she brings a unique balance of clinical experience, expertise, research, and grassroots leadership. Her work in promoting healthy aging and accessible elder care earned her the prestigious WONCA World Rising Star Award in 2021. Thank you, Dr. Noor Hazana.
Hello. Yes, thank you, Dr. Ko, for your introduction. And can you hear me very well?
Yes.
Okay, that's great. Okay. So so thank you again. So actually I'm a family medicine specialist and have a subspecialty in geriatrics and primary care. And actually I would like to share what we have done in our community. But basically, before this, I work in Pandamaran Health Clinics, and actually, I just transferred to Bestari Health Clinics, which is actually in different district. By the way, um, how to say that? I know this is a platform for infectious disease, but my previous experience is actually most of my patient is actually comes from non-communicable disease, who's actually like diabetes, hypertension, come for follow-up, something like that. But I think maybe we can adopt and adapt what we can do or what we can start from Malaysia setting, because I can say that the integrated elderly healthcare in a Malaysia setting, I mean in community perspective, is actually how we can say that it's quite baby stage. Yeah, even though we have tried to start it from a free, I mean some years. So yes, without without further ado, so I just start. So as you all know, that Malaysia is projected to be aged nation by 2030, and when all the population age 60 over has reached 15%, and the life expectancy of the Malaysian population has increased to 75 years. This is way back 2 years ago, and whereby woman is actually elderly woman is actually longer, okay, around 78 years. And we all know that with population aging, there will be rise in age-related condition, including frailty, dementia, falls, sarcopenia, malnutrition, immobility, chronic pain, polypharmacy, mood disorders, and so on. And older person is actually have complex needs and require variety of services, including healthcare, social care, and special rehabilitative service. And so we know that there's an increasing need to integrate various health service, coordinate care for the older person, and we need to shift from curative to preventative care to contain the escalating of healthcare costs. And to date, older person in Malaysia and caregivers actually face challenges in assessing what we call that comprehensive older person care service to meet their complex care needs, as it's actually uncoordinated, fragmented, and structurally and systematically. And through evidence-based, the implementation of integrated healthcare for the older person is the way forward. And we know that. Okay. So I just want to share what is actually our elderly healthcare services objective. It's actually introduced in 1996 under the 7 Malaysia Plan, and it's actually part of expanded scope of family health services. And it's actually based on the National Healthcare Policy for the Elderly, which actually emphasize on healthy, active, and productive aging, and to empower elderly families and communities with knowledge, skill, and environment. And this is actually to lead to achieve optimum level of health for the elderly through comprehensive integrated healthcare services. Another objective is actually to improve health, of course, to improve health status of the older persons, to encourage participation in health promoting disease prevention activities throughout life course, to provide age-friendly, affordable, equitable, accessible, culturally acceptable, gender-sensitive, seamless healthcare services in holistic manner at all levels, to advocate and support development of enabling an environment for independent living, aging in place, and to collaborate with all agencies. So this is to share with you all what we call that public health framework across the life course. So this is actually our mantra. And any elderly may experience periods of high and stable capacity, declining capacity, and significant loss of capacity. And each of these 3 periods requires a different approach. And for those with declining capacity and significant loss of capacity requires the ICOP approach, or we call it integrated care of older person. Yeah, so I will share about this ICOP approach later. And as you all know, for high and stable levels of capacity, the goal is actually to build and maintain this level for as long as possible. and actually to emphasize on disease and risk prevention, to ensure acute problem adequately addressed, and detecting and managing chronic and non-communicable disease at early stage. For declining capacity, the goal is actually to delay, slow, or even partially reverse the trajectory through targeted interventions and risk factors reduction strategies. And for example, for aerobic exercise is actually important for cardiovascular disease prevention, but for frail patient, exercise that can help build muscle mass, strength, and balance is very important. So this is actually the different that we are actually looking. And for significant loss of capacity, the twin goals are to optimize clinical trajectories and to compensate for these losses through the provision of social care services. And clinical intervention should continue to focus on recovering and maintaining capacity, including ongoing disease management, rehabilitation, palliative intervention, and end-of-life care. And rehabilitative service can help to prevent permanent functional disability and care dependency, reduce hospital admission, and delayed discharges. All right. So another issues and challenges that we are foresee for older people population is such, yeah. Of course, we are discussing about the health now, the psychology support, financial, family issues, transportation. This is very important because a lot of patients is actually have difficulties to come to my clinics. So I think this is a real issue for elderly. I think this is also same with the others, yeah, and access for food. Okay, all right. So another issues and challenges, this is actually based on National Health Mobility Survey 2018, whereby 1 in 10 has dementia, 1 in 6 have functional decline, 1 in 10 has depression, 3 in 10 have lack of social support, 1 in 7 had history of fall in the year, 30% has malnutrition, 28% have diabetes, and 50% have hypertension. And in 2015, survey found that older people is actually are the highest users of our public health services in our clinics, hospital, and emergency departments. And as we said, integrated elderly healthcare is actually the way forward in managing older people in holistic manners. So this is actually the best approach, and this is what I would like to share more, right? And the integrated care for older people, or ICOP, is actually a framework developed by WHO to address health and well-being of elderly, whereby it focuses on promoting healthy aging and preventing decline in physical and mental abilities as people grow older. And this ICOP approach is actually emphasized person-centered care, okay, comprehensive assessment, multimodal intervention involving multidisciplinary team, integration of care, whereby we're coordinating care across different healthcare providers, services, and settings, and empowerment. Yeah. And the goal of ICOP is actually to help the elderly to maintain their independence, improve their quality of life, to prevent or delay functional decline. And this is actually important approach in primary care setting to address the specific need of them. Another thing that I would like to share is actually importance of case managing. This is actually Prisma Canadian model, which highlight the importance role of case manager, serve as a crucial link in the healthcare system for older people, helping to integrate care, improve outcomes, enhance quality of life, and provide support to both patients and their families. And case manager play a crucial role in integrating care among older people for these reasons, yeah. Coordination of care, policy advancement, advocacy, communication, preventing hospital readmission, resource coordination, cost-effective care, quality of life, and as patient-centered care, actually case manager ensure the care plans are tailored to the individual goals and preference. And another things that I would like to share here is the comprehensive geriatric assessment, as mentioned by Dr. Brandon just now. It's a thorough and multidimensional evaluation of elderly physical, functional, cognitive, emotional, and social well-being. And it's actually a systematic approach to understand the individual needs and complexities of elderly, typically performed by a multidisciplinary team of healthcare professional. As I mentioned in the slide here, as involve physical, psychological, social, economic, and not forgetting the functional assessment. Okay, so here I would like to share what we have done in Pandamaran Health Clinic. So basically, I'd like to introduce a bit about what is the background of the Pandamaran Heart Clinic. It's type 2 clinics with a daily attendance of 800 to 1,000 patients in a day, with a population coverage about 120,000 population, with the elderly 15,000, around like that, 13%, yeah. And we actually have staff, our resources actually with heart clinic staff 137 at that time, and 3 FMS with 23 medical officers, 13 paramedics, allied health staff, yeah, pharmacists, nurses, and supporting staff. And we actually have a lot of program, and we are actually having electronic medical record, and this is similar like what they call that other big health clinic in Malaysia. Okay. All right. This is actually our team for the for our unit. We call it Unit Penyayang, which involve multidisciplinary, led by FMS, yeah. And also, we also have what we call that collaborators from health advisory panels, non-government organization, yeah, particularly involved in senior citizen background. And we also have Kelab Warga Emas, or we call it Senior Citizen Club. So actually, Panama Heart Clinics has officially acknowledged as a center of excellence for elderly last year. And the objective of this, we call that setting, is actually providing a one-stop center, improve access to screening and early intervention at primary care, coordinating and facilitating the referral of patient from community to KK to hospital, or vice versa. Address gaps in existing multidisciplinary and agency services through local service coordination and integration. Next is actually empowering the management services of chronic patients, neglected senior citizens cases, like in domiciliary home care services, through a dedicated team. Increase awareness and involvement of elderly healthcare among the elderly, caregivers, and families. This is actually to improve the health, well-being, and quality of life of the elderly. And of course, another objective is actually to reduce hospital burden and service costs. So this is our landscape integrated elderly healthcare in Pandamaran Clinic, where it actually has 3 evolving phase. We have started in 2016 as a wellness program, and this program is actually led by FMS. This senior citizen club is actually what they call that is a wellness program. I will explain this one in the detail after this. And since 2016 to 2022. But then after COVID, we actually renamed this wellness program to Self-Help Healthy Aging. Okay. And the next phase is actually phase 2 in 2018. This is seamless geriatric care led by geriatrician. It's actually to improve networking between health clinics, hospital, and community. The next phase 3 is actually 2020 until now. This is actually led by FMS, where we call it comprehensive adult assessment pathway, where it's actually very focused in the clinics. So we want to increase what we call that the quality of care in our patient in our clinics. So if you could remember the public health framework just now, for high, stable, and capacity. Okay, so this is actually why we create this wellness program in community, because we want to those with those elderly independent, yeah, and those volunteer to join. We actually encourage them to join our program. Before COVID, actually we do this every week, half day session, and we have what we call that a schedule. We plan it in a year, and involving multidisciplinary team. And there is what we call that exercise and the screening that we have done, education talk by multidisciplinary, and a lot of activities actually we have done with them. Then after COVID, because of the space issues, and we have to um, uh, do it in the weekend, in the month, something like that, two times in a month. Yeah, we have to reduce the frequencies. Yes, and of course, for this, we actually have the budgets come from our health advisory panels. And we don't receive any specific budget from the government, but we actually try to lies and networking with the NGOs to ensure this program runs smoothly. And this is the program that we have rebranding, the Healthy Aging. This project is actually, we have received grant from Selangor State under self-help program. And this is actually NGO-led program and fully supported by government agencies. Okay. And now the good things is actually this program is become official program under Selangor State, and is actually expanded to the other district. Yeah. And targeting before this 2,000 people, but now they increase it to 2,700 senior citizens to have this benefit.
Hazana, you have 5 minutes.
Okay, sure. And this is actually focusing on preventing frailty among elderly. And next, this is those with declining and significant loss of capacity. So those patients that we have seen in our clinic, when we cannot manage in our clinic setting, so we have what they call that discussion with the geriatric teams from the hospital. Initially, our discussion is actually, go to each clinics. But then since COVID, we have to modify the discussion through a virtual online. So we have done it so far every month, every Wednesday, something like that. Yeah. And yeah, so this is the thing that I've said. We have the schedule, and we also have the what we call that template for discussion online. Yeah. And those from the discussion, those that need attention from the geriatrician, so we will refer. Okay. And then this is example of the case that we seeing in our clinics, those with declining capacity. Yeah. So with the multiple fall and a lot of issues lah, and we use this what they call that ICOP screening program. Yeah, ICOP checklist. And this is actually the things, the NGO is actually helping patient bring them to the hospital, and then a session with physiotherapists, and also the NGOs also bring for COVID vaccinations. And a lot of things actually not done by me, is done by the team. Yeah. So the success story for this patient is actually, this patient have recurrent falls, and it's actually when we do the assessment, it's actually because of the roof is actually leak, and this is actually providing slippery floors and the risk of falling. So we actually communicate with the Lembaga Zakat Selangor and the community leaders, and they have repaired the client house. This is another example, patient with declining capacity, and this is significant loss of capacity. This patient have stroke, and we have done a home visit. Yeah. All right, and then this is another program we did with the NGOs, preventing fall. Let's kemas rumah. Okay. All right. So this is what they call that, another things that we can empower our volunteers and the community to prevent fall. So this is actually basically the framework that we share the integrated community-based elderly healthcare services in a seamless way. And we actually adopt and adapt the public health framework with ICOPE approach and use comprehensive geriatric assessment to assess the frail elderly, and using case management strategies to discuss identified complicated geriatric case for further intervention, including appropriate referrals, home visit. And the issues that we are struggling now is actually coordination care of the case manager lah. So it's actually would be best if we could have system, how to say that, integrated electronic medical records, okay, from health clinics and also hospitals. So so that we can do more. All right. And this is actually our dreams. Okay, I think I end my presentation. Thank you.
Thank you, Dr. Nohazana. That is amazing to see what you've managed to set up at your service. Not just integrating medical care, clinical care, but allied health and NGOs and all the different parts of community to support the elderly. So we have time now for a discussion or Q&A. Would anyone like to pose any questions to our two speakers? No one hands up. I might start with one for Jaime. You mentioned very briefly that you have an app in your service that helps with appointments and reminders, I think. Are there any other examples of use of technology in this service to assist with care?
Yes, I mean, this app that we have is an app that was developed specifically for managing stable patients. And what it does is essentially kind of empowers patients to have some of the data from the clinic. So they get results pushed over to them, and also they get appointments, and also they get a little bit of two-way communication. Now, the problem with aging is that there is still a lot of digital divide. There is a lot of digital illiteracy, and that happens also in people that are older. So relying only on digital technologies might be complicated. Having said that, I think the dementia, particularly the dementia kind of area, is quite well advanced in using technology in terms of, using technology to monitor patients, for example, and technology that we can get access to. So even things like these sort of speakers that people have at home, for example, can be quite helpful for patients to remind them to take medications, to be able to, if they have an emergency, being able to communicate with services and so on. That can be helpful. There's also different devices that can be used to monitor for falls, for example. There is a device called the Q-Talk that we have evaluated in our clinic that gives you an idea about risk of falls and so on, that community nurses, for example, could take to patients' houses and assess for people's risk of falling and so on. So yes, I think this is a really, really important area of work. And I think the future probably for elderly, not only people with HIV is quite bright. There is a lot of devices that are out there. I even saw one in China where they were using like an exoskeleton to kind of help people going up the sort of the wall when they were kind of, because it's quite very stiff sort of area. So I think that's the sort of thing that is coming to kind of help patients so they don't fall. So I think technology will play a huge, huge role in terms of monitoring, being able to kind of link up with health services and potentially offer practical help for patients that are frail and at risk of some of these geriatric syndromes.
Thank you. No, Hosanna, can I pose the same question to you? You spoke about, I think, integrated electronic patient records across the services. Can you see any other use of technology in your service, in your model of care that could assist in delivering care or monitoring?
Okay. Apart from EMR, I could foresee having the case managers to coordinate the care, because I can see that when we have trained case managers, it would help a lot in coordinating care and also delivering care for the elderly patients, because this is actually very important task to remind them to come back, because you see, we actually try many ways, and we actually lacking on that part. And if you could see, in a primary healthcare setting, we have a lot of programs running, and it's actually multitasking. And we actually, to ensure the success of each program, is actually the dedicated team itself. And of course, when there's a case manager availability, is actually, of course, will help in terms of improve the quality of care that we actually give to our patients. And apart from that, another things that I use very, maybe this is quite simple, where we use what they call that, we actually have our telephones, and we keep all our patients' number in the phones. And that is actually another example how we could remind them. But then, of course, who want to do this? Yeah, and of course, we need the people who want to do this, who are actually the case managers. For the time being, we actually have a great support from the what you call that, our Ministry of Health, where they actually give us what they call that, one paramedics to handle this. But then in terms of training, it's still not adequate. Yes. So I think there's a lot of things that we have to do. And of course, still need a lot of support from our ministries. Yes.
Thank you. Thank you. We've got there's a question in the chat that from Zhu saying technology is very good. In rural parts of Malaysia, the accessibility is limited. What is the best solution for this? Any of our Malaysian hub members have any thoughts on this? Or maybe Noor, Hazana?
One thing that I can say is that even in places like in the UK, where you think that there is access to all type of technology, flexibility is important. We even have, these patient-reported outcome forms that come digitally, and patients want to complete it on paper. So I think flexibility is absolutely key, and we should just make sure that we have all potential options for people. Of course, people use mobile phones, and some of them have smartphones, but some of them don't. Some of them cannot even read. properly because they don't have proper problems with their eyes. They have cataracts and so on. So if we just have one service that is gonna be doing just digital stuff, you might be actually missing out in a lot of people that perhaps are gonna be excluded. So I think our service just need to be accommodating, making sure that we have
Yeah.
full flexibility and offer every possible option for patients.
Thank you.
I think
And
I
I
think
think one of
Grace
the
and
issues,
Jenny. Sorry, I think Grace and Jenny have their hands up. So
Grace?
Oh, hi. Very quick, two very quick comments. The first is in response to the term of frailty. In fact, when I'm from Hong Kong, and the term in Cantonese is actually very stigmatizing, and I really would avoid that. And what I usually do would be something similar. I would explain to patients that we are doing some functional assessment. So I think that might be more attractive even to younger, older patients. So this is one comment. The other one is a follow-up on the technology thing. I think one of the advantage for people aging with HIV is that in terms of the chronological age, they're actually much younger than most of the usual geriatric patients. And from our experience, it's usually they are less afraid of technology and more receptive. So I believe we actually can use this as an advantage in improving our services. And my question for the two speakers is really, I'm very impressed with all the integrated services that you have explained in your settings. And one of the major challenges in my setting is to really find the people who are interested to set up this integrated services. So I do have some rather traumatic experiences, like engaging our geriatricians. We do have an amazing geriatrics team in our hospital, but some of the professors are maybe retiring soon, and I do have very interested younger geriatricians in the past, but some emigrated to UK and some go to private practice, and it's really hard to maintain these form of integrated services. So I'm just thinking whether training our own HIV physicians to do at least some of the geriatric care. So for example, in the ICO pathway, I think at least for the first maybe 1, 2, 3 steps, it probably can be done in the clinics by HIV physicians or even trained nurses or other medical assistants. So what are your thoughts on this strategy?
Can I go first? Because I think this is an excellent question. So just before that, about your comment about the sort of frailty term, and that is so critical that even before we start doing anything in any of the services, we just need to understand what the context is with frailty and the stigmatization of aging, because that obviously happens and that can be a barrier. With regards with the integration of services, you're absolutely right. It can be a struggle to kind of involve other healthcare professionals in this. I don't pretend that we should set up all combined HIV and geriatric clinics like the Silver Clinic, because they can be expensive, they can be difficult to deliver. So we really need to come up with a model that is going to be kind of taking those principles of holistic care, patient-centered care, and the 5 M's to be able to be implementable. So thinking about maybe moving out of the clinic and going to the community, maybe training nurses to do a rapid comprehensive geriatric assessment supported by a MDT, for example, that might be in the hospital with the HIV physician, and maybe a geriatrician would be keener to kind of do that because they don't have to necessarily have a whole list of patients to see, but they can offer some help in terms of what things to do. And maybe it's a different model that we need to develop that is more cost effective, implementable, and rapid to deploy, because a clinic like the Silver Clinic, of course we started, but it is still quite heavy. I mean, it's expensive, right? You have 2 geriatricians, you have a nurse, you have the pharmacist. It's just fair. You think about your own setting, you think, oh, how am I going to set this up? So I think it's more about the principles and how we can do that. And absolutely right with you that maybe we need to train other healthcare professionals. Having a therapist, for example, would be helpful. Having a physician assistant might be helpful, with the support of the primary care, family care, and geriatrics, and obviously HIV.
Okay. So from my perspective, can you hear me? Okay. So basically, definitely, I would agree with Dr. James just now. And of course, we need to set up team. That's very important, multidisciplinary team. And don't forget to involve dental, because I mean, initially when I set up, from my experience, I forgot to include them. And when there is issues with dental, so it's it's you have to find another way how to integrate with them. And then of course, to involve the NGOs, non-government agencies, because all these volunteers is actually they are actually good in supporting the non-clinical supportive. As example, the transportation, and then to ensure patient is actually coming to the clinic, something like that. And of course, the team itself must be trained. And of course, looking into the what they call that the staff, our staff, clinic staff, the training must be simplified and easy to understand, and very practical. And one of the experience that I would like to share is actually I also ask them to go for attachment in the geriatric clinics, and to see what is actually the example of cases that they would see in the dedicated clinics, in the dedicated geriatric clinics. And then with the logbook, we also have the logbook. Okay. And of course, we also have to look into the space, because since we have a lot of programs in our clinic, so we have to find a space and what is actually the best day to handle this program. All this we have to look for setup. And of course, support from our superior. And of course, this is very important to ensure your program is actually run smoothly. And of course, to expand this program, like what to share when I work when for example, the program that I think successfully networking with the state, the what we call that, the frailty prevention program in the community, whereby we do it in outreach community. That is actually what we call that, another things that we can develop, the networking with the politicians, or with the stakeholders who's actually have interest in elderly care.
Thank you. Might go to Jenny, who's got her hand up.
Thanks, Ken. I would like to echo Grace's frustrations in trying to set up an integrated care clinic for older people with HIV. I've been trying to do the same thing for the last 4 to 5 years. My barriers are financial, as well as how do we encourage our colleagues to join our clinic. Our patients clearly just want to come to the one place rather than having to go to 6 different places to be assessed and to have interventions implemented. So I absolutely agree with you, Grace, and if you figure it out, please tell me how you do it. But my question for Jaime is, do you use mainly electronic resources to ask the patients to complete the different assessments? And are those assessments automatically uploaded into the electronic medical record? Or are they filled out on paper, PDF'd, uploaded, never to be seen again, or compared with another assessment a year later?
Thanks, Jenny. So in this era of artificial intelligence, we do the paper, we do the scanning, and we put it in the EPR. So very simple thing. And normally happens because the nurses tend to do an assessment before the patients actually walk into the room with the geriatricians and the HIV physicians. So normally the patients come a little bit earlier, sometimes the day before, sometimes a week before. They have the assessments, which is 2 or 3 patient-reported outcome forms they completed with the nurses if they need any help. And then it's on paper, and we actually have a look at them, and then everything kind of goes scanning into the EPR. I mean, I wish we had something that be this smoother, but it kind of works because some of the patients, again, are quite elderly and frail, and they have difficulties actually working technology. I mean, there might be ways that we can get kind of work around this, but so far that's been the most efficient, funny enough, some way of actually doing it. So nothing really fancy. It's really just paper, scanning, PDF, going to the EPR, and then we can actually see what is been happening.
My experience with paper and scanning into the electronic medical record is that it goes into different parts of the record depending upon who's scanning it in. And to have a comparison with the next time that assessment is done is quite difficult.
It is.
We've been playing with quality of life, and we can now get our patients to complete a quality of life assessment that automatically goes into the electronic medical record, where we can actually compare functional, psychological, physical scores over time, which would be great if we could do that with everything, really.
Yes, we're getting a new system, so hopefully that will be incorporated. So fingers crossed, it's no more problems and more headaches rather than solutions. But yeah.
Thank you. Julia, you've been waiting patiently. Would you like to go ahead?
Right, so thanks, Ken. Okay, Jaime, you presented your study in terms of what are the concern of the patient from your clinic, and I see that physical decline is the top. Right, just wondering, is it a global trend for elderly HIV patients? Because when I see Dr. Nur Hazana presentation on our mobility survey, I know it is not HIV specific, but in the elderly in Malaysia, it seems that dementia and depression is above functional decline. Functional decline, in fact, is number 3 or number 4. But depression and dementia are the top 2. And I'm just wondering, Puli, do we have any data for our HIV elderly in terms of that mobility? Because I feel that the information is something that's very useful in terms of prioritization, since all of us have lack of resources.
I mean,
Yeah.
this is interesting because, again, it's the patients that write this. It's not the doctors that are interpreting what the patients are saying, if that makes sense. So I think that patient-reported outcome form, what it shows is essentially what the patient is complaining about during the last 4 weeks. So a lot of physical sort of complaints. We're kind of dissecting that a little bit more, but I can tell you that things, for example, like pain and mobility can go into that. Sometimes there are issues, for example, related to sleep. There are issues about mental health illness, but we tend to kind of screen for mental health anyway in the sort of a standard HIV clinic, so we kind of have those scores. But a lot of the complaints were physical, and there are complaints that are more kind of cognitive that also kind of overlap a little bit with mental health illness. But again, it will be interesting to see what your patients actually write if they are given the opportunity to kind of say, well, what are your, you're coming to the clinic, what are your main complaints in the last 4 weeks? What do you want us to do? And what I was saying is that we don't set the agenda. It's the patients that really set the agenda for us to be able to kind of work with them. I have had situations where the patient's main agenda is, look, I have this rash, I want this rash out. Whereas my agenda is, well, I need to do the CT scan because this patient might need, I think we were investigating for a possibility of a PE or something like that. And the patient is like, I'm not having any more scans. I don't want to go to another appointment and so on. So it's that thing where, where do you go? But ultimately, if we're doing holistic management and patient-centered care, this can be helpful. But yeah, it will be interesting to see your population.
We do actually have that data. So Reina and I have been working on a HIV and aging cohort, mostly focused at our own hospital. And actually, cognitive impairment, we do have quite a high prevalence with a median age of like 45 or so for our cohort. So about like 25% would have cognitive impairment. And I think depression as well is probably about 20% if I'm not mistaken. And this is like a younger age group, right? So I think we can see that if you take elderly at like 60, 65, already at 45, we are seeing that. So that's why we're trying to build our clinical services to be able to at least screen for these things and figure out a linkage to care for them.
Thank you for that. I just wanted to ask Cheng Hong, you're in Singapore, I believe. Do you know of any integrated services with HIV and geriatrics in Singapore?
Thanks for asking me this question. I hope you can hear me okay. I'm an advanced practice nurse or nurse practitioner. So in Singapore, I work in NCID, National Center for Infectious Disease Cases, and our center is seeing the biggest cohort of PLHIV currently. So we do run a surveys which is led by nurses for comprehensive geriatric assessment. And this clinic is supported by a multi-D team. We have geriatrician, we have HIV physicians, and we have a regular multi-D team discussion. Yeah, so that's basically what we do. We are seeing a very similar picture as what you all share. So our group of patient age much more early, and there's a lot of comorbidities, social isolation, mood issues, and also substance use. And with all this, making the diagnosis of or management of cognitive impairment very, very challenging, because a lot of time we cannot really diagnose cognitive impairment just yet, because there is certain diagnosis you have to exclude other possibility. So we are really working with other specialists, psychologists, psychiatrists, and also some neurologists on our group of patients. But coordinating care is a challenge also. And I often realize that sometimes we refer a patient to specialists, but they will not turn up for first visit. The stigma is really, really very strong. So sometimes we will really pace with them, so find out what is really important to them. So have a goal of care discussion. So a lot of time that will help patient to determine whether they want to continue to see the specialist, or they will be following up in our clinic. Yep. So I mean, it's not easy, and we are also still exploring best mode because a lot of patients have polydoctoring. They have appointment fatigue. They have an appointment like 3 or 4 appointments every month. I cannot imagine how they manage that. So it's really not easy.
Thank
If
you.
I may just say, it's interesting about the cognition, because I think it's a big problem, to the point that when we started doing the sort of geriatrics clinic, we realized that we were getting a lot of that, and there wasn't even enough time during the comprehensive geriatric assessment to kind of evaluate cognition. So we set up a memory clinic, which kind of function in a slightly different way. So most patients now that they have a specific cognitive symptoms tend to go there, because sometimes it's just the cognitive symptoms and patients actually not frail. So they kind of go in a slightly different pathway, but it is an issue because it's very multifactorial. So you really need to kind of dissect what is going on. A lot of it related to mental health and other things. But yeah, it's interesting that you highlighted that, Dr. Shane.
Does any participants have any questions for our speakers or for our hub members? Or any hub members wish to comment in country, if there's any services similar to what's been discussed tonight?
Again, I was just gonna say that I'm very happy to kind of help in any way I can, because obviously I have an interest in this, and we've been kind of fighting these fights for quite a long time to be able to set up these services. So I'm very happy to kind of be contacted, have meetings, trying to kind of understand and and do that. So yeah, just please do send me an email. And yeah, happy to kind of have a chat, because I know how difficult it is to kind of trying to find a friendly geriatrician that is going to help, the friendly sort of dementia specialist that might be interested. The funny thing is that once they come and see our patients, they're like, oh, wow, this is really interesting. They're quite different to the usual patients that they have. And then they get hooked. And I tell you, it is possible. I have dementia specialist that comes from Nottingham just to do the clinic with us because he absolutely loves it. And similarly, one of our geriatricians doesn't work in our hospital anymore, and she comes back just to do that clinic. So it's all about finding sometimes the right person to kind of get involved and do it. So it is possible. I'm an optimist anyway. So feel free to contact
Thank
me.
you. Farah, how would people get Jaime's email? Would they just contact you, perhaps?
I put it in
Yeah.
the chat, but again,
Or you put in the
happy
chat?
to be
Okay.
contacted. Put it in the chat there.
Thank you for that. So we've got a few minutes left. Farah, how much
I think we
do
are
we have
good
time for more
to,
discussion?
I think we're
Or
good to
should we
wrap
be?
up.
Yeah. I'll hand over to you, Farah.
All right, thank you. So regarding Jaime's email, you guys can also get it from IACO platform. Just scroll over to the session 11 session, and you can find Jaime email at the subject matter expert in that. Yeah. But if you cannot find it, you can also email Age Positively Gmail as usual. Hold on, let me just share the slide. Oops.
And also, you want to come to Brighton and then see what we do, and you're visiting the UK, feel free to contact me. I think Puli was in Brighton and she saw the thing in action as well. So yeah, totally open for that as well.
All right, thank you, Jaime. Yeah, so just before we end the session, just to remind you guys, the next session will be by Miss Cheng Hong, where she will be sharing about advanced care planning. So for this session, we actually haven't got any case presenter yet. So if any of you have a case to present or have any experience to share, we're open to that. So please email us if you are interested to present the case. Yep. So for feedback, I also have chat on the chat box just for you guys to fill out this feedback form before we end the session, or else I can email you later on the feedback form, as well as the CPD hours for Malaysian. Don't forget to fill out the CPD form. Yep, I think that's about it. So I will email any of you if regarding the feedback and also the CPD form, as well as the case presentation actually. Yep, I think that's about it. Puli, is there anything else?
No, Farah, thank you. I just wanted to say that next month is our last session of 12. So hopefully most of you can make it and join us, just, to have a nice wrap up of everything. Thank you very much.
Brilliant.
Thanks, Jaime. Thanks, Harzana.
Have a good evening.
Thank you. Bye,
Thank you,
everyone.
everyone.
Thank you.